BPH, enlargement of the prostate gland caused by hyperplasia, not hypertrophy. Prostate tissue covers the urethra where it passes through the prostate, leading to LUTS symptoms. No clear patterns with race. Heavy in the UK, Canada, US. Black men greater than white men in the US. Increased rate with fat, obesity in the abdomen. 4th, 6th, and 9th decades in life is the prevalence. Related to aging, at birth the size of a pea and continues steadily until the end of puberty, and then there is rapid growth until the age of 30 when the prostate reaches adulthood. Around 40 to 50, benign hyperplasia begins and continues slowly until death. Causative theories focus on endocrine factors, androgen estrogen ratio, chronic inflammation, effects of autocrine, paracrine growth stimulating and growth inhibiting factors. With aging, circulating androgens are associated with BPH. Clinical manifestations: bladder obstruction flow, LUTS, delay in starting a stream, urinary frequency, decreased force of urination, urinary retention after years of progression, leading to overflow incontinence with an increase in intra-abdominal pressure, hematuria, bladder or kidney infection, bladder calculi, acute urinary retention, hydroureter, hydronephrosis, renal insufficiency. Evaluation: medical history, physical exam, lab test, urinalysis, rectal exam, DRE, and PSA to determine hyperplasia. PSA alone cannot diagnose. DRE on patients over 40 years and high risk. In moderate to severe symptoms, a transrectal ultrasound to determine bladder and prostate volume. Urinalysis, serum creatinine, BUN, uroflowmetry, post-void residual, pressure flow study, cytometry, cytourethoscopy to determine bladder and kidney function. Treatment: alpha adrenergic blockers, prazosin and tamsulosin to relax smooth muscle of bladder and prostate. Anti-androgen agents, Proscar, block androgens and shrink the prostate. Newer invasive agents such as interstitial laser treatment, transurethral radiofrequency procedures, and transurethral needle ablation, TUNA, and cold thermotherapy. Prostatitis, inflammation of the prostate. Unknown prevalence is limited to the gland's excretory ducts. The National Institute of Health classifies prostatitis into 4 categories: acute bacterial prostatitis, AMP, chronic bacterial prostatitis, CMP, chronic pelvic pain syndrome, CPPS, asymptomatic inflammatory prostatitis. Enterococci and Enterobacteria AC found in the GI flora are usually the cause. APB and CBP, commonly E. coli, is the cause of infection. CPPS, while causes are unknown, stem from immune inflammatory, neuroendocrine, and neuropathic etiologies. Category 1, or ABP, is a UTI prevalent in men 30 to 50 years of age and BPH in men of advanced age. The prostate swells, becomes tender, firm, or boggy in an inflammatory response from the infection. Other common causes are following cystoscopy or catheterization, Men present with malaise, sudden in onset, low back pain, pain in the perineal, painful ejaculation, rectal pain, high fever and chills, dysuria, inability to empty their bladder leading to urinary retention and nocturia. A narrowed stream, common in a urinary obstruction caused by edema, compressing the urethra, is a medical emergency. Pain in the prostate, when in an upright position, comes from the pelvic wall muscles tightening and compressing the prostate. Urinalysis and culture are needed to isolate the organism and prevent complications. Complications range from urinary retention to abscess, with the possibility of rupture into the rectum and surrounding areas, bacteremia and septic shock, epididymitis. During acute stages of infection, urinary catheters are a contraindication, and suprapubic catheters are recommended for urinary retention management. Category 2, or CPD, is chronic UTIs, usually from gram-negative bacteria, as the most common form of prostatitis in men. Symptoms include frequency, urgency, and dysuria, perineal pain, low back pain, sexual dysfunction, malaise, and arthralgia. Repeated infections can cause the prostate to become fibrotic, firm, or boggy, and irregular in shape. After normal urine sample free of bacteria, the prostate can be massaged to express secretions. After expression, the first 10 milliliters of urine immediately after massage are examined with a microscope. An infection is determined if there are more than 10 WBCs per high power field with macrophages containing fat. This sample can then be cultured to diagnose organism. Pelvic X-ray or ultrasound can rule out infectious calculi, common in 50% of men, and ultrasound the bacterial source and recurrence of UTIs, and is the aim of treatment. Category 3, or CP/CPPS, is when no bacterial source cannot be linked to the prostate. Category 3A is inflammatory CPPS. WBCs are elevated and only found in the prostate. Symptoms are consistent but less intense. This non-infectious prostatitis is linked to the backflow of sterile urine into the ejaculatory ducts, resulting from high-pressure voiding. Category 3B is non-inflammatory. Bacteria associated with CP/CPPS include P. aeruginosa, Helicobacter pylori, and E. enterobacter. When bacteria are absent, men report a dull pain that presents like a spasm or continuous in the suprapubic, infrapubic, scrotal, penile, or inguinal regions. Painful ejaculation or urinary frequency. During assessment, the prostate feels normal. Diagnoses are given after everything else has been ruled out. Cystoscopy, bacterial cultures, prostatic fluid evaluation, urethroscopy, and urodynamic studies. Category 4, or asymptomatic inflammatory prostatitis, is when men are without symptoms but have WBCs and bacteria contained within the prostate. Paraphimosis versus phimosis. Both are disorders of the foreskin, or the prepuce is too tight to move easily over the glans penis. Paraphimosis is a condition where the foreskin is retracted and cannot move forward or reduce to cover the glands versus the opposite of phimosis, a condition in which the foreskin cannot retract back over the glands. Both cause penile pathological conditions. Inability to retract the foreskin is normal in infancy and caused by congenital lesions, which during the first 3 years of life separate naturally with penile erections and are not an indication for circumcision. Phimosis can occur at any age and is commonly from poor hygiene and chronic infection, and rarely occur with normal foreskin. Reasons for seeking treatment include edema, erythema, tenderness of the prepuce, and purulent discharge. Inability to retract the foreskin is a less common complaint. Circumcision is completed if needed after bacteria is eradicated. Complications of phimosis are inflammation of the glands, blantis or prepuce, prostatitis, and paraphimosis. There is a higher incidence of penile carcinoma in uncircumcised males, but chronic infection and poor hygiene are a higher underlying factor. 60% of invasive penile carcinomas are from HPV. Paraphimosis, where the foreskin is retracted, can constrict the penis, causing edema of the glands. If it cannot be reduced manually, surgery is done to prevent necrosis of the glands due to restriction. Severe paraphimosis is a surgical emergency. Peyronie disease, bent nail syndrome, fibrotic condition that causes lateral curvature if the penis during erection. Develops slowly and is characterized by tough fibrous thickening of the fascia in the erectile tissue of the corpora cavernosa. A dense fibrous plaque is usually palpable on the dorsum of the penile shaft. Usually affects middle-aged men and is associated with painful erection, painful intercourse for both partners, poor erectile distal to the involved area. In some cases, impotence or unsatisfactory penetration occurs. When penis is flaccid, there is no pain. A local vasculitis-like inflammatory reaction occurs, and decreased tissue oxygenation results in fibrosis and calcification. The exact cause is unknown. Is associated with uterine contracture, a flexion deformity of the fingers and toes caused by shortening or fibrosis of the palmar and plantar fascia. Diabetes, tendency to develop keloids, and in rare cases, beta blocker medications. No definitive treatment for disease, but medications and surgery can be used. Spontaneous remissions occur in 50% of individuals. Men with a significant penile deformity should be considered for surgical correction. Priapism, an uncommon condition or prolonged penile erection, generally painful, and is not associated with sexual arousal. Idiopathic in 60% of cases. Remaining 40% of cases can be associated with spinal cord trauma, sickle cell disease, leukemia, pelvic tumors, infections, penile trauma. Considered a urological emergency, treatment within hours is effective and prevents impotence. Conservative approach includes iced saline enema, ketamine administration, and spinal anesthesia. Needle aspiration, if the blood from the corpus through the dorsal glands, is often effective and is followed by catheterization and pressure dressings to maintain decompression. More aggressive surgical treatments include the creation of vascular shunts to maintain flow. Erectile dysfunction results in up to 50% of prolonged cases. Ballantitis, inflammation of the glans penis, usually occurs in conjunction with prostatitis, and inflammation of the prepuce. Inflammation of both is called blepharophthitis. Associated with poor hygiene and phimosis, the accumulation under the foreskin of glandular secretions, smegma, sloughed epithelial cells, and mycobacterium. Smegtitis can irritate the glands directly or lead to infection. Skin disorders, psoriasis, lichen planus, eczema, and candidiasis must be differentiated from inflammatory resulting from poor hygiene practices. Most commonly seen in men with poorly controlled diabetes and candidiasis. Treated with microbials, post-infection circumcision is performed to prevent recurrences.